Okay. Happy New Year and a very good morning to everyone. I'm Professor Naicker from Rehab Medicine Unit, Department of Orthopedics and Traumatology. And it's with pleasure, my team will discuss a case of a child who presented to us with predominantly a gait and musculoskeletal problem. But we take this opportunity here to highlight other underlying issues and the need for a multidisciplinary approach in managing this child holistically. So with that, I would like to welcome our panelists, radiologist, Associate Prof. Faiza, rehab physician, Associate Prof. Rashida Ismail, our pediatrician, Dr. Tanjan Earn, our peds neurologist, Prof. Wong Sao Wei, our physiotherapist, Muhammad Taufik, and occupational therapist, Puan Haslina. So without further ado, can I give the floor to our medical officer, Najwan, to kickstart today's program.
Thank you, Prof. Amara. I'm Najwan, medical officer under Rehab team. So today, we presented a case of a 6-month-old girl, which was referred to our center with reduced movement of the bilateral lower limbs. The developmental milestone was up to age except for the gross motor of the lower limbs. Perinatal history, antenatally, mother is at 34 years old with a non-consanguineous marriage with no preconception folic acid intake. And she is also was a group B streptococcus carrier during the pregnancy. Birth history, baby was born term and the birth weight was 2.79 kilogram with vacuum assisted delivery due to poor maternal effort. There is no hydrocephalus, otherwise noted neonatal jaundice requiring single phototherapy during birth. She had a history of recurrent admission for UTI also during at 6 months of age. However, no visible urinary dribbling was noted, with daily fecal soiling was noticed in the diapers. So with this is the developmental milestone for this patient. Otherwise, gross motor for the upper limb was normal, and the fine motor, social and cognitive also was normal up to the age. Neurological examination, upper limb was normal. Otherwise, the lower limb was noted. The bilateral limb, lower limb is flail with hypotonia, and the power is around 2/5 in the MRC grading with hyporeflexia and lax anal tone. Otherwise, posterior noted the hip was abducted with flexed knees and also plantar flexed ankle with no muscle atrophy or fasciculation. Our spine examination noted there's a dimple around 7 cm from the anus. Otherwise, there's no presence of swelling or half of tear noted over the sacral area. So the differential diagnosis for this kind of cases with lower motor neuron lesion will be either spina bifida, poliomyelitis, or spinal cord infection or spinal cord tumor. So we need further investigation to get a provisional diagnosis. So in this case, we did a blood parameters which was normal, and radiological examination such as an ultrasound spine, ultrasound kidney, uterine and bladder, and also MRI spine and brain. So with this, I would like to invite Prof. Faiza from the radiology department to further explain regarding the MRI spine and brain.
Assalamualaikum warahmatullahi wabarakatuh. Very good morning to Prof. Amara thank you very much for the kind invitation. And Dr. Syed Najwan, you've requested some investigation, which I will share now. Okay, so what we have here is a 6-month-old baby, and I just highlighted three specific investigation that can help in terms of the management of the patient. So the first one is we did an ultrasound kidney uterine bladder that was in 2017 in December. What we see is that so this is the urinary bladder, Okay, and then behind the uni bladder should not have anything, but in terms of any cystic or fluid-filled structure. But here we do see a two dilated distal ureter. This is on the right side and this is on the left side. If we go to the upper tract, we do see that there is dilatation of both of the left kidney. So this is the left kidney with quite a significant dilatation of the proximal ureter as well. And then we do see the right ureter, the right kidney also dilated with a dilatation of the right ureter, and it goes all the way down to the distal ureter as we saw in the first image. So in the conclusion, the patient actually has a bilateral moderate hydronephrosis and hydroureter. So if we saw this, then we have to give a differential diagnosis of vesicular-ureteric reflux. Bilateral, so that means we should also exclude a posterior ureteral valve. But in MCUG that we did after that, it actually show, in MCUG we give contrast into the uni bladder, and then we see whether the contrast has gone and opacifying the ureter, which was not supposed to be. In a normal population, we only see the uni bladder being filled and also the urethra during the maturation. But in this child, we have both of the ureter being opacified. So this is on the left side, which is quite tortuous and dilated. And this is on the right side. So I did not show the later image, which actually showed this contrast actually gone and opacifying the dilated upper tract, both on the right as well as the left. And we grade the vesicular reflux based on the opacification of the contrast into the ureter and kidney. So in this child on the right side, she had a right grade 3, so which and basically this is how it looks like, and it opacified the renal pelvis, but does not cause significant dilatation, just a mild dilatation. Whereby on the left side we graded the child as a left grade 4 to 5 vesicular reflux, meaning the ureter is dilated, and then more proximally you do see that the pelvis is already ballooned up. So the child also had an MRI spine that was done before that, but as you can see, from this view, this is the cervicothoracic vertebrae, T2, because we do see the CSF is bright, and then T1, the CSF is not bright. And looking at this, it looks quite normal in the first glance, but if you scrutiny the one on the lower part of the thoracic spine, you do see some dilatation of the central canal here. Okay, so and as we go down, which I think the most region of interest based on the child clinical assessment. So what we see is that this is the area of the lumbosacral spine. Okay, so we do see that there is a mass that is bright on T2, and it is also bright on T1. I will show you later. But the thing is, this mass actually occupies in the spinal canal that cause widening and expansion of the spinal canal at the level of the lower lumbar to the upper sacral region. So this is at L5, S1, S2, and then we have 4, 3. So from L3 to S2, this mass occupies then, and then it goes to the more lateral towards the exit foramen. So this is on sagittal, as if you are looking at the child on the side, and this is on axial, as if you are looking at the child from above. You can see that the mass, this is from below, the mass actually causes expansion, and as we go up, it does cause quite a significant involvement of the spinal canal, and it causes widening of the spinal canal. And this is the spinal cord. So the thing is, the spinal cord in this child actually lower than a normal population, because normally the cornus medalis of the spinal cord should actually ends around the region of L1, T12, L1. But in this child, it actually goes down towards the L3 level, so that means it is low lying, and it is there is a central canal dilatation plus the mass, or we call it as a lesion. This lesion is on T2 is hyper intense, and on T1 it is also hyper intense. And on STIR images, which is a fat saturation image, we can actually see that the mass is fully being suppressed by the signal of the mass being suppressed, and that means this mass actually contains fully fat component. And this is just to show you the axial. So this is the T1 and T2, so bright, and then it's being suppressed on the stir. And so what so I just show you the normal MRI spine that we should see. So this is the spinal cord, and the cornus medullary or the spinal cord should ends around the region of T12, L1. I should not be beyond the pedicle of L2. So in that patient, it is low lying. So after the cornus medullaris, it will go to and becoming the chorda equina. Okay, so that's how it looks like. This is T2 and this is T1, and we are seeing in this case, actually I forgot to show that the patient actually does have a tract, but the tract does not the subcutaneous tract, but it doesn't contain any fluid. This one. It's suppressed, and it just actually goes towards the spinal canal here. Okay, so that's a sinus there. So what is the cause of T1 hyperintense structure on MRI? I mean, I have a list here, but I think in our case is fat because it is suppressed by a sequence that suppress fat signal. So I think I can skip this embryology, but basically I just want to show you this case actually belongs to the based on the embryology, because of the neurofold and the neurocrest, and then it folds, and then it becomes a neural groove, and then after that the neurocrest forms, and after that the skin will close with the ectoderm, and then we have a neurocrest that goes around the neural tube. So, ectoderm will become skin and subcutaneous tissue. Neural tube will become brain and spinal cord, and vice versa. And the notochord itself here, which is the endoderm, it will become the vertebral column. So the thing is, spinal trapezium is divided into open and closed. If ever the neural groove or the ectoderm does not close, like this one, it will become an open spinal trapezium. So this does not happen. So the developmental arrested at this point. So you will get myelomeningocele, Chiari tumor formation, vice versa. However, if let's say the embryology has gone and becoming and it closed, I mean the ectoderm closed, and then you have this. So I just show you, this is the example of a open spinal trapezium whereby you don't see skin overlying this lesion, and that is in Chiari tumor formation. But in closed, we have with subcutaneous mass and without subcutaneous mass, and these are the list of the causes of spinal trapezium that can give rise to this. This is an example of a spinal dysraphism with subcutaneous mass in a case of lipomyelocele. And this is when it goes out, I mean, the sacral, the sac, the thecal sac goes out and become a lipomyelomeningocele because the neural liquid is also being extruded into the subcutaneous tissue. This patient, however, actually has a simple dystrophic state with of a closed spinal dysraphism without subcutaneous mass. This is the patient's image. So this child actually had an intradural lipoma. Okay, I wouldn't, and also she had an associated dermal sinus. I wouldn't talk about the complex thing, but what I just want to point out, in our case, the lipoma actually located at the dorsal midline, and it actually contained within the dural side of the lumbosacral region. So it can, normally patient will present with TAJUK syndrome. So so just one slide on the TAJUK syndrome. It is a clinical syndrome. I have to stress it. It is a clinical syndrome. So in radiology, we would not report as a TAJUK syndrome, but what we will just report whatever that we see. It's a low-lying spinal cord. We can see an intraspinal lipoma because a normal radiology would not exclude TAJUK syndrome. Okay. So so just to show you, this is the summary of it. And this patient lies in the closed spinal trapezium without subcutaneous tissue. So I think with that, I thank you. Thank you for having me.
Okay, thank you, Prof. Faiza. Now that we have a diagnosis to work with, I would like to invite Dr. Tan Jen Eun, our pediatrician, to delve deeper.
Yeah. Good morning, everyone. Thank you, Prof. Amara, for the kind invitation. Okay. Okay, can you see my slideshow? Okay, today I'm going to share about the neurological perspective on spinal bifida. Okay, just a very quick introduction. So spinal bifida is a spectrum of congenital abnormalities characterized by an incomplete fusion of the midline mesenchymal bony or neural elements of the spines. So as you can see, and what was shared by Prof. Faizal earlier, so it can divide into open and closed spinal bifida. So on my left, you can see the spine. This group, we call it spinal bifida occulta. That way, where you can, there's no clinical features when you check on clinical examinations. So the skin and subcutaneous tissue is relatively intact. Whereas in open spinal bifida, you can further divide into two groups, which is myelomeningocele and meningocele. So the difference is mainly whether the spinal cord and the nerve roots were protruded into the meninges area. So I think I just have a quick share with you regarding the embryology. So spinal bifida can occur as early as 4 weeks of gestation. So the primary neurulation, as shared earlier, happened within the first month of gestation. So if it does not close by first month, so spinal bifida may occur. So these are the main clinical features that you might find in the patients with spinal bifida. So in open myelomeningocele or meningocele, I think that's clear cut and you can see a mass of protrusion from your spinal regions. Whereas in closed spinal dystrophism, this might be the only closed. So you may have just a sacral dimples which our patients show, or a tuft of hair. Okay, so who are at risk of develop spinal dystrophisms? So I think some of the risk factors has been identified. So mainly nutritional costs, I think non-folate, maternal folate deficiency and also B12 deficiency are the main risk factors for spinal bifida, which contributes to about 5% of the total case. The second was the environment factors. So maternal obesity and diabetes did contribute to spinal dystrophism as well, but the hypothesis wasn't very clear, where the use of anti-seizure medication, especially sodium valproate, did contribute to some of the cases of spinal dystrophism, especially with the doses of more than 600 mg per day. And lastly, I think genetic factors with MTHFR gene mutation did contribute to spinal bifida, which I will elaborate further in my next slides. Okay, so to understand about the mechanisms of spinal bifida, so one very important cycle of or we call it folate and one carbon cycles, where you can see on my right. So this is the folic acid is important for the DNA synthesis. So if you look at the pathway, in any interruption to disrupt the folic acid pathway will give you a risk of becoming having spinal bifida at birth. So if you look at the second pathway, so where this 510 NTHFR before it further metabolized into MTHFR, so you will go through another cycles which require vitamin B12 to tetrafolate. So at this point, you can see the MTHR gene, if it's disrupted, so it will affect the cycles, and vitamin B12 did play a role, and high dose of valproic acid use also will disrupt these cycles. So by understanding this cycle, so you can identify that actually the risk factor for spinal bifida. Okay, so now I will talk about some cranial anomalies associated with spinal bifida. So I think as explained by Prof. Faisal earlier, I think the commonest association was carry mouth tooth formation, where there's a tonsillar herniation of the cerebellum into the foramen magnum and further cause upwards pressure, causing secondary hydrocephalus. In severe form, you might see anencephaly and also encephalocele. Okay, so for cherry malformation, there are basically two types, type 1 and type 2. So the main difference is in type 1, the cerebral displacement or we call it downward herniation did not cause significant pressure causing the hydrocephalus, but it caused more pressure towards the spinal cord, and it ends up the patient will develop syringomyelia in the later on. While in type 2, the pressure or causing more of an upward pressure causing hydrocephalus. So syringomyelia is one of the complications that might happen later in life when there's chronic pressure to the spinal cord. So it's basically cyst formation from the center of the cord. So when it started earlier, in a small region, so it will mainly affecting the spinal thalamic tract. So the sensation will normally being affected first. When it's expand later on, so it will affect the motor nucleus. So the motor weakness will be more markedly, and further on when it further expand and affect the spinal cortical spinal tract, so the motor dysfunction will be even worse. So it usually affected the lower cervical or upper thoracic regions rather than the lower lumbar sacral regions. Okay, so for the treatment options wise, I think there's no exact treatment, but mainly on symptomatic relief. So some of them may have presented with this pain, chronic pain, so the analgesic or anti-inflammation will help. If the neurological dysfunction is really marked, so some surgical intervention may be needed, as for example, posterior fossa decompression or neuroplasty. Okay, so next is mainly about theta cord syndrome. Okay, I think it has been shared by Prof. Faisal earlier. So theta cord syndromes the risk of it happening is higher when you have some structure attaching to the theta cord, prevent the spinal cord from moving or growing. So for example, in our case, there's a huge lipoma that's attached to the cordus medullaris. So it causes the patient to have a higher risk of theta cord syndromes. So the clinical manifestation is mainly when there's any significant change in your either sensory, motor function, and even autonomic function. For example, change in the bowel habit and bladder habit. And it usually happens when the patient have a growth spurts. Okay, so next is neurogenic bladders. So as we know, our bladder there's a pontine maturation center and also sacral maturation center to control our bladder functions. So when the spinal cord function is affected, so it depends on the level. So if it's affect mainly the sacral maturation center, which is a lower sacral region, S2 to S4. So mainly the somatic, so mainly the sensory function will be affected. But if you affect at a higher region, so T10 to L2, so the hypogastric nerve will be affected. So you will see a more variable type of neurogenic bladder. Okay, so to simplify it, it can be divided into 4 types. So mainly A, B, C, and D. So, okay, what was it? The first type, so the innervation of the bladder and sphincters are both affected. So there's a hyperactivity of the sphincter and also destrusor underactivity. So it will mainly cause a very unsafe bladder where there's accumulation high pressure in your bladder cavity that cause it to be distended and backflow as well. So it's classified an unsafe bladder. So the intervention will be keeping it dry with a CIC, clean intermittent catheterizations. So the second form, the B types, is when you have both destrusor and sphincter hyperactivity and cause even higher pressures. So this condition will give rise to reflux nephropathy. So the patient will need a CIC and even anti-cholinergic such as your totiradine or oxybutynine to relieve the bladder muscles. The third type will be the destrusor and sphincter underactivity. So in this condition, it will be quite safe, but the leakage will continue to happen. So you will still need a CIC, but if the leakage is too severe, you might need an outlet surgery to be done. And the fourth type is destrusor overactivity and a sphincter underactivity. This is a condition also is classified as unsafe, and because it's frequently wet, so it gives rise to higher risk of urinary tract infections. So this type of condition, you may need a CIC with your anticholinergic, and in severe cases, you may need some outlet surgery to be done. Okay, so for follow-up of this condition, I think the frequent investigation that we need to do, of course, your ultrasonography, MCUG to look for your features of reflux nephropathy as shown by Prof. Faizal earlier. And also the MSA renal scan is needed to look at the function of the kidney and see whether there's scarring as a result of the reflux and nephropathy. And in certain cases where they don't respond well to your anticholinergic and CIC, a urodynamic study will help you to determine what form of bladder status is the patient having. So lastly, it will be the neurogenic bladder. So of course, when the same nerve, the hypogastric and also pudendal nerve are affected, so it will affect your bowel movement. Yeah. So I think the level of treatment for this, I think most of the patients for all patients, they definitely will need a routine diet and lifestyle alterations. But since most of the patients, they will come with this HUS2 or Bristol 1 to 2. So sometimes they may need some digital stimulation or evacuations in a more severe form. So they may even need a transanal irrigation or anterior colonic irrigation where you need a stoma to facilitate all these interventions. So to summary, I think these are the neurological complications of a case of spinal bifida. So possibility of Chiari malformation, triangomalia, Theta cord syndrome, neurogenic bladder, bowel, and not to forget the MSK related complications as a result of motor and sensory dysfunction. Yeah, thank you.
Thank you, Dr. Tan. Yes, that was quite an exhaustive list of problems associated with the spinal cord disorder. So can we move on to understand what goes on at the musculoskeletal level? For that, I would like to invite Prof. Madhya Rashida Ismail.
Okay, Assalamualaikum. Very good morning. Before I start with our rehab management, I would like to invite our medical officers, Dr. Arun, to present the current status of this child. Dr. Arun, please.
Okay, so for the hiccup. So currently I'll present with continuation of the current function of the child. So the child is attending a SBDC mainstream standard 1, is able to follow syllabus in a class, is able to read and write well. Patient is able to do arithmetic addition and subtractions up to triple digit, and she's like to go to school. So for the activities of daily living, the child is able to do grooming by herself, bathing by herself, and feeding by herself. Upper body dressing can be done by herself, and the lower body dressing can be assisted by the mother and father. So for the bladder function on CIC every 2 to 3 hourly, assisted by mother, and for bowel, she's able to BO daily with occasional heart stroke, not requiring medications. And the ambulation, ability with the reverse walker and wheelchair, and using wheelchair and school will limit their facility, but so far this class is a ground floor. So on the physical examination, you can see there's a small skin tag over the lower back. And you can see from these images that her joint is quite supple for position. And for the bridging, part, I'll play a video. So this is a form of bridging exerciser. So we can see she's a very weak hip extensors. So this is the other video. So when the child goes up, you can see she is unbalanced and unable to maintain it for very long. So from the clinical examination, there's for the motor function, the hip abduction, for the both side power according to the MR3 grading is 2/5. For hip flexion is 3/5. For knee extension is 3/5, and from L4 and below is 1/5 for the knee flexion and ankle dorsiflexion, and for the ankle plantar flexion is L5 and S1. There's only 0. There's no muscle movements. So the reflexes for the knee and ankle are absent. There's no clonus, and for the child, the sensory level is preserved up to level L3. So now I'm showing you the gait without orthosis. So we can see the first, she's having a difficulty to propel herself with the overpronated feet. Okay, at the same time, you can see she's having hyperlordosis, which is a poor lower body muscle strength, and you have fleet foot. So the current issues are being managed by a few multidisciplinary teams. So explained by the Dr. Tan earlier. So for the functional, for the gait and mobilities, for the ideal activities, I will hand over to Prof. Rashida to continue with her presentation. Thank you.
Thanks, Dr. Arun. Now, I would like to highlight on the rehab aspect of managing patient with spina bifida. Yeah. Okay, so I would like to focus on musculoskeletal issues and rehab management approach in managing patients, a child with a spinal bifida. Yeah. Okay, so first, what is rehabilitation? So it comes from the Latin word rehabilitate, so meanings to make fit again. So let's say if the child has an illness, we want to make sure that they regain the maximum self-sufficiency and function in a normal or as near normal function as possible. Yeah. So as we all know, the spinal bifida is a neurotube defect, we also known as a spinal dysraphism. So usually it's associated with the cognitive issues, especially if they have an underlying hydrocephalus, yeah, and psychological issues, neurological deficit because of the spinal cord involvement. Because of that, they can present with the neurogenic bladder, neurogenic bowel, and musculoskeletal issues. Yeah, and they have problems with the activities of daily living and functional issues as well. So now I would like to focus more on the musculoskeletal issues. So as we all know, patients have multiple medical problems, so we need a multidisciplinary team approach. So we involve those specialty involved in managing patients with spinal bifida. So pediatric neurologists, nephrologists, rehab physicians, neurosurgeons, etc. And as well as an interdisciplinary team approach, meaning our rehab team, including rehab physician, physiotherapists, occupational therapists, prosthetists and orthosists, social worker, etc. So just to let you all know that that's the reason we have a joint spinal bifida clinic in our hospital involving other different various specialties. So before I highlight on musculoskeletal issues, I want to give you some overview. So musculoskeletal issues depends on the level of the lesion. So if the patient has a low lesion, S2, 3, 4, spinal cord has already ended, and mainly the sacral, neurogenic bladder and bowel issues, and usually they are ambulator, so not so much about the MSK issues. For L5S1, that is, patient has an ankle dorsiflexus, plantar flexor weakness, so they need a ankle foot orthosis, short ankle brace, and they may need to use a crutch. For L4 level, they have an ankle dorsiflexor weakness plus knee extensor weakness. So in these patients, they need a little bit of higher bracing, and they may prefer to use wheelchair for long distance. L2 to 3, so the knee extensors are weak, maybe hip muscles are weak, so that's why they usually prefer to use wheelchair for long distance. So T12 is both lower limbs are weak, so usually they are the wheelchair user. So our patient is like a mid-lumbar region. So that's a reason, as Dr. Arun has mentioned, she has weakness in knee extensor, ankle muscles, plus the proximal hip muscles. So what happens is if the child is having a lesion at the thoracic and high lumbar, they become sedentary at the age of 7 to 10 years. For low lumbar, 70 to 80% maintain walking capacity to adulthood. But sacral level is the best prognosis, 98% can maintain walking capacity at adulthood. So just to highlight on musculoskeletal complications, it depends on the level of the lesions. Let's say L5S1, in these patients, the ankle plantar flexors and dorsiflexors are weak, and he walk on the equinovarus foot. So they are prone to develop a neuropathic ulcer and bursitis. Yeah. Okay, this case is a bit similar to our case. So the weakness starting from the hip, knee, and ankle. So because of the proximal hip muscles weakness, they are prone to develop a hip subluxation and dislocation. So because of this hip subluxation, it causes a pelvic tilt. Because of this one, they are prone to develop a scoliosis. Yeah, these all can be prevented by using early intervention with the orthosis. Yeah, okay. And since they spend most of the time on the wheelchair, they tend to develop a pressure ulcer. So this all can be prevented as well by using a proper cushion, proper offloading technique. Yeah, because of the poor mobility and loading, they have a risk of developing osteopenia, osteoporosis, and fracture. And Charcot osteoarthropathy, early osteoarthritis, overuse syndrome because of the abnormal biomechanic, low back pain, and those with a wheelchair user, they tend to develop a shoulder pain. So that's the reason rehab should commence as early as possible. So they should be on physiotherapy, occupational therapy, orthosis, especially for high lesions. So look at this video. This is our patients. This is a frontal plane motion. So normally when we walk with the heel toe gait. Our heel should contact first. Yeah. So obviously this girl, she is struggling too much of her upper limb muscle power to propel her body forward. So meaning she has a poor lower limb muscle power, but she can still, able to walk with abnormal biomechanics. So her foot is overpronated. This is a sagittal plane motion of the patients. So you can see foot is overpronated. It's like a flail, no muscle power. Knee extensors are weak, and we can't appreciate the knee locking mechanism in this patient. And she has a lordosis spine, and she is using too much of her upper limb muscle power to propel the body forward because of the proximal muscle weakness. Yeah. So what are we going to do? I have already mentioned list of complications. We want to prevent it. To prevent it, make sure you optimize the biomechanics. You should address the biomechanic issues. So first, we want to stabilize the foot problem. Yes, now his foot is overpronated, so we need to stabilize the foot to prevent other MSK issues. So we use an anchor foot orthosis. This is a plastic, thermoplastic splint. So what is orthosis? So orthosis is an external device applied on the existing body part. Yeah, body part must be there. Yeah, it's different from prosthesis. Prosthesis is an artificial limb that replaces the missing parts. That is the keywords. Yeah, so to augment the function of the limb. Yeah, so this orthosis would provide mediolateral ankle stability. It can control the mediolateral ankle movement. So when the child walks, at least her foot will be stable, and it prevents dorsiflexion, plantar flexion, because the child limb is very flaccid. You have to stabilize it. Yeah. Okay, let's look at the video. This is without orthosis. This is with orthosis. What is the difference is when she landed the foot, the foot placement is way better than without orthosis, but she is still struggling to walk because proximal muscle weakness are very obvious, So we can only control the ankle. The gait pattern is a little better, and then the speed is faster. So when we look at this is from frontal plane. So when we look at from the sagittal plane motion, okay, so you compare the sagittal plane motion. Foot placement is better, knee is a little straight, but proximal muscle weakness is still appreciated. Yeah. So what will be the next? In the meantime, okay. So this is a similar patient, similar problem. So you can see her proximal muscles are weak like our girl. So you can see like a trendy lumbar gait. Yeah, when she land on one side, the pelvic drop. Yeah, so we say lumbar. Why proximal are so weak? Because of these two reasons. So proximal muscles, trendy lumbar gait is positive. Trendy lumbar test is positive in patients with the weak hip abductors, which are your gluteus medius and minimus. So why? We say it's lumbar, and why proximal so weak? Because your gluteus medius and minimus is supplied by the superior gluteal nerve, which is L45S1. Again, gluteus maximus, hip extensor, we appreciated during the clinical examination. Her weak extensors are weak. Her weak hip abductors are weak. Okay, hip extensors are supplied by inferior gluteal nerve. The root value is L5S12. So if something wrong at the lumbar lesion level, these proxima are very weak. So that's a reason, although they have a low lesion, so-called like L5, we can still see the very, obvious gait abnormality. Okay, so this guy also same, we start with the AFO. We try with a little higher bracing, knee, ankle, foot orthosis. Still, because of the proximal muscle weakness, you can't correct this trendy lumbar gait. So what will be the next option? Actually, it's similar to our patients. What we need is a higher bracing. Higher bracing means you need to control until hip level. So sometimes it's not so practical to have a higher bracing because it's very costly. We need a lot of training. Child need to be a little bit intelligent, cooperative, and family support is very important. Okay, so look at this one. So this orthosis, we call it a hip, knee, ankle, foot orthosis or reciprocating gait orthosis. This is a cabling system. So when she propel one side by using the trunk muscle power, because with the cabling system cause hip extension. That's why reciprocating. When we walk with hip flexion on one side and opposite side is extension. So this is a reciprocating gait orthosis. Yeah. So family support is very important. So that is our long-term plan for this patient. So I just want to highlight the orthosis. How does it look like? Yeah. So currently our girl is using a posterior walker for ambulation by using orthosis. But our long-term plan will be hip, knee, ankle, foot orthosis. But we need to give some time and we need to do a lot of assessment. She will benefit from the wheelchair for long distance mobilization because we want to avoid, stress and strains on the lower limb, too much. So she will benefit from using wheelchair for long distance mobilization. If let's say she becomes weaker because of the theta cord and because of the MSK issues, if she becomes a wheelchair bound or her mobility is very much limited, we still have a long-term plan. We still need to encourage all our kids to stand. So, okay, so why we need to stand them? Because of the benefits of standing. So this is a general benefits of standing. So if let's say her mobility is poor, she cannot walk too long, and just a short distance, then we will encourage her to use a standing device to stand. So that is our plan. So why? By standing, the child can improve, able to perform her activities of daily living, and it promotes the pelvic alignment. By standing, reduce loading on the ischium, prevent ulcer. Yeah. By standing, all the joints, muscles are stretched out, so prevent contracture. And by standing, you stimulate the gastrosoleus contraction, so increase venous return to the heart, prevent deep vein thrombosis, and stimulate autonomic nervous system as well. By standing, your sensory input and proprioceptions are stimulated. By weight bearing, can prevent osteopenia, osteoporosis. Because of the gravity effect, it can improve your bladder and bowel function. It's good for your psychological function as well. So in conclusion, we need multidisciplinary team approach in managing patients with spina bifida. And we encourage therapy as early as possible. And early intervention with orthosis and assisted standing is important, especially in higher lesions. If MSK complications occur, prompt treatment is needed. Yeah. Last not the least, health education to the family members are crucial. Thank you.
Thank you very much, Prof. Rashida, for that very comprehensive management, rehabilitation management. Now, while there are many options in terms of the ambulatory devices and needs, we also need to know what's going on behind the scene as far as the therapy is concerned. So I would like to invite Muhammad Taufik, our physiotherapist, to enlighten us on how they actually get this child a bit more ambulatory.
Good morning, everyone, and thank you, Prof. Amara, for the kind invitation. So I'm going to explain the physiotherapist assessment and some of the intervention that I have done for this patient. Let me share my screen first. Okay. Basically, the case review is the same. Six-year-old girl, underlying lipomengosal of L3 and L4. MRI for the spine is done in July 2016, and congenital cross-spinal dystrophism with intradural lipoma causing cardiac presented with bilateral lower limb weakness since birth. And this patient was referred to physiotherapist at the age of 6 months. This is the first session with physiotherapist. For the birth history, born full term, 7 weeks via vacuum-assisted delivery. For second stage of postnatal, neonatal jaundice for 10 days, require for the therapy for 5 days. So this is the developmental milestone, the past developmental milestone, but I'm going to focus more on the gross motor development. So I already tabulate the gross motor development. During the 9 months old, patient able to sit up, and then during 3 years old, able to crawl, sit without support, but not able to pull to stand, and then the right side weaker than the left side. During 3 years and 6 months, patient able to stand without support, but only for a short while. And currently, this is the current assessment. Patient now able to walk, but with using reverse walker and AFO. So the objective assessment that I've done for this patient is first is the general observation. Then the body size, 7-year-old girl using AFO bilaterally. And then patient use wheelchair for long distance ambulation. She can use reverse walker, but easily get tired during the ambulation while using walker. Upper limb is actively moved, and for the sagittal plane movement, able to flex hip and extend the knee. This is the myotome assessment. For the hip flexion, 3 out of 5. Hip extension, 1 out of 5. Knee extension, 3 out of 5. For the knee flexion, 1 out of 5. Ankle dorsiflexion, 1 out of 5, and then absent in plantar flexion. And then for the upper limb range of motion is basically active full range of motion. For the lower limb, for the non-functional muscle, it's passive full range of motion. For the muscular control for this patient, the trunk control is good, but the hip and knee control is fair. And then the motor skill for this patient, patient able to sit independently, crawling independently, standing by holding into support a walker, walking by using a reverse walker, and then for climbing stairs, a patient will do crawling movement. For the gait analysis, I don't have video for this patient, but this patient is same as Prof. Rashida patient, so you can imagine from the video, the gait video just now. For the trunk, patient will have a back lean during swing phase, and the pelvis is tilting anteriorly. For the hip, patient will have inadequate hip extension during terminal stance and excessive hip flexion during mid swing. For the knee, patient also have excessive knee flexion during mid stand, and for the ankle, the foot flat during contact, no heel off. The initial contact of the middle side of the left foot is the initial contact for the left foot is on the middle side, and the initial contact for the right side foot is on the lateral side. For the foot placement, foot posture is overpronation of left foot during mid-stand and hind foot valgus, and the right head of left navicular is patient have no arch, meaning reduced head on the left navicular. And then for the bed mobility, patient able to roll independently, full body to long sitting independently, and also sit on the edge of bed independently. Transferring from bed to wheelchair and also wheelchair to bed, patient able to do independently but with supervision. And transition from high sitting to standing, patient also able to do it independently. And for the active daily living, dressing, patient able to do for shirts much more faster than trousers. Eat and drink independently. Toilet and bath need moderate assistance. For the locomotion, home locomotion, patient prefer crawling than using walker because she complained of easily getting tired. And outdoor, patient will use wheelchair more. Okay, so this is the functional mobility scale. For 5 meters, patient prefer crawling. For 50 meter, patient can use walker, but still needs support from his father to make patient walk in a straight line. So prefer for 50 meter, she will use a wheelchair. 500 meter, wheelchair. So this is the analysis based on ICF. For the impairment, patient has flaccid paralysis involving L4 and L5 downward, weakness on functional muscle of quadriceps, in hip and knee control during standing, low fitness level, improper gait during walking, improper foot placement during walking. For the functional movement, patient still need moderate assistance in toileting and bath, unable to climb up stairs properly, unable to use walker for long period of time. So for the participation, patient unable to participate with physical education at school and restriction in leisure activity. So for the intervention that I have done for this patient is called muscle strengthening. So I've done a wheelbarrow exercise to strengthen the back muscle, also 2-point kneeling plus rolling forward and backward, and also then high sitting on gym ball while the upper limb play with therapy. And for the upper limb strengthening, patient can do push up on the bar, and also for the tricep muscle, and we also do push up on gym ball. For intervention for the lower limb, do sit to stand exercise and also obstacles, but on the parallel bar. For the ambulation, patient has her own reverse and posterior walker, and patient use this walker to achieve more upright position during walking, and DFO to decrease the pathologic moment across the ankle, and wheelchair to lessen the energy consumption. The future goals that I put for this patient are for the impairment, able to strengthen the functional of quadricep muscle, to improve her hip and knee control during standing, and also to increase her fitness level, and also to get a better posture during standing and walking. For the functional movement, my goal is patient to help to get able to do self-care without any assistance. But because by the moment she still need moderate assistance from her mother and father. Okay, so and then able to ambulate using walker for long duration, because by the moment patient not prefer to use walker because she complain of tired, easily getting tired, and then able to do more active in standing position for longer duration, because patient now prefer to do most of the activity in sitting. And then for the participation, patient able to walk in the park with walker instead of wheelchair, able to join some of the physical activity at school.
Thank you, Taufik. Yes, ambulation always is the main focus for parents as well as for the kids, as kids need that ambulation to get along in life with their friends, go to school. But what's equally important is also their functional activities of daily living. So for that, I'd like to invite Puan Nur Haslina to give us some insight into what can be offered to this child.
Okay, thank you, Prof. Good morning, everyone. I am Haslina, occupational therapist. You all can see my slides. Okay. First of all, occupational therapies is actually this is an outline of my presentation, Introduction to Occupational Therapy Roles in Spine Bifida, assessment that we use for patient, occupational therapy management, chronological progressions, and goals for patients. Okay, occupational therapy actually assists to daily tasks such as eating, dressing, personal hygiene, and helping with motor movement skills. For hand skill training, to train for hand manipulation, hand coordination, and bilateral coordination movement. For preschool and school intervention, to cognitive stimulation, to readiness for schools, plan to prepare to school intervention, for school and home visit within a 10-kilometer radius to assess environments and home assessment, and we advise aids and adaptation if suitable for patient. Okay, let's move to the case presentation, case discussion, RW, a referral by Pegawai Perubatan, date of referral 25 July 2006, and reason for referral actually for sensory stimulation, and status actually defaulted after COVID-19, and then we get new referral on 12 December 2020, attend session 6, absent session also 6. And then for occupational therapy, I use no standardized assessment, pediatric evaluation checklist to get information about the family history, patient demands, and patient abilities, and observation during hands-on training. For standardized assessment, we do the short sensory profile to identify sensory modulation problems, P-body developmental motor skills, to pediatric evaluation of disability test, to assess ability of patient, and the fine motor in classroom to assess motor skills and precision, also motor speed in the handwriting skills. Okay, sorry. Sorry, Prof. Share screen. Should I start again, Prof? Sorry, I just continue from
Yes,
when
please carry on.
okay, for assessments. Okay, for the short sensory profile, this is the result of typical performance or for all aspects in sensory modulation disorder, which means there is no problem with a sensory modulation disorder for this patient. And P-body developmental motor skills, I use 5 motor domains for grasping and visual motor integration. This standard score is 15 for grasping, and visual motor integration also 15. This means there is no problems with fine motor for grasping and visual motor integration skills. Okay, for pediatric of disability test, pediatric evaluation disability test, PEDI, modification frequencies for self-care is too extensive modification need for bladder management, and pants, especially remove and put on pants will help, and mobility, routine rehab modification needs for indoor locomotion, outdoor locomotion, and stairs. For social function, there's no modification needed. Okay, this is the result for fine motor in classroom to assess writing speed and precision. For pencil grasp, a patient is dynamic tripod, and then motor age is more around 10 years old, which means more than her age. There is no radio arm function, appropriate scissor works, and rating. There is no deficiencies in hand skill development. Okay, the next is a chronological progression. During 8 months, patient in terms of gross motor, there is no head leg, able to put on seat, and able to roll over from supine to prone. For fine motor, patient able to reach toys and transferring toys, use thumb finger grabs and grabs and release toys. For Rehab skill, able to hold bottle for feeding at the age of 8 months. At the age of 2 years and 2 months, in terms of gross motor, there is no head leg, able to sit and support with a straight back. For fine motor performance, patient able to tower 4 to 6 cube, able to put pellets in a bottle, and able to play with puzzle, which is able to match 2 puzzles in correct shapes. And self-help skills, patient able to hold spoon for feeding, and able to brush teeth with help. Okay. At the age 2 years and 11 months, for fine motor performance, able to string beads around 6 square beads, able to remove the top bottle with minimal help, and able to tower more than 8 tubes. In terms of self-help skills, try to put clothing with the help. Okay. At the age 3 years and 4 months, in terms of gross motor, patient able to stand with support. For fine motor, able to copy, circle, vertical line and horizontal line, and able to color within the line. And for self-help skills, patient able to brush teeth, able to dress for upper extremities, and able to feed herself independently. At the age of 7 years, patient able to stand with support and walk with working frames, a fine motor handwriting, able to write, and a good speed and precision in writing. For self-help skill, patient able to brush teeth independently, able to dress upper extremity, able to feed herself, able to button a shirt. But in the lower part, patient need help to wearing a pants and shoes. Okay, this is the goal of patients. For long-term goals, most independent in self-care. For long-term goals, to independent in dressing for lower extremities, and able to put on pants independently, able to maintain sufficient postural control to allow the extremity to complete tasks for the lower extremity skills, and to be independent in putting on shoes. Okay, that's bring me to the end of my presentation. Thank you.
Thank you, Puan Haslina. So can I open the floor to any questions? You can type in the Q&A chat box. Are there any questions? Okay. So in the interest of time, if there are no questions, I would like to wrap up by saying that we can see how varied the rehabilitation interventions are. And thus, early referral is not only necessary for enhancement of function, but also for prevention of complications. And what is important is teamwork, especially so in a very complex birth disorder like spina bifida. And what's equally important is the understanding of what each discipline can offer and the value that they bring to the table that can add to the holistic management of this client. And that's why we here at HCTM do have a specialized monthly spina bifida clinic that acts like a one-stop center to bring together several disciplines to manage and improve quality of life of children with spina bifida, who otherwise would have to go through all these very many individual clinic follow-ups and procedures throughout their life. And this can get very stressful for the family. So thus, a very good understanding and coordination among team members and family is imperative, along with proper planning and structure and definitive timelines and goals of management. The idea of holistic management is to go beyond disability and illness into wellness and social integration. So with that, I wish to thank my colleagues for their kind participation, as well as a very informative sharing and discussion session. So we hope this has been useful to you. And if there's still no questions, I think we can move ahead with the quiz.